Again, everyone, good afternoon and welcome to this spiral session on treatment or management and one of the 10 sessions under the clinical and public health track of the first National Hospital Week Research Forum. All right. So again, I'm Dr. Terence John M. Antonio from the Health Facility Development Bureau, the session chair for this session. And with me is our session coordinator, Ms. Joanna Joy Lico, our Development Manager Officer 2 from the Research Performance and Monitoring Division naman po of HFDB as well. Next slide, please. So each of the researcher presenters in this session will have 15 minutes to present their papers. This will be followed by a 10-minute question and answer portion to give the audience the opportunity to raise their questions and clarification. So just a reminder for our audience that for this particular session, they will all be put on mute in the entire session, and you can submit your questions to the chat panel of this virtual session room. You can see the button at the bottom of the screen, at the bottom right of the screen. And to manage our time for the Q&A, we'll be allotting at least a maximum of 1 to 2 questions per presenter only. Um, as a process, also kindly identify first the presenter you wish to ask the question before asking your question. We would encourage our audience to ask or submit the questions. And if ever that mas marami pa pong questions yung masasubmit, we'll try to answer as much as we can also. Towards the end of the session, we will have the synthesis and some onward announcements in the forum program as well. So for this particular session, we will have 3 presenters. So the first one will be Dr. Marlon Galvez of the Philippine Heart Center to discuss the AEPEI scoring system to predict mortality among patients diagnosed with infective endocarditis after surgery at the Tertiary Hospital, a retrospective analytical cross-sectional study done in the Philippine Heart Center as well. This will be followed by the presentation of Ms. Lorraine Yasay from the St. Louis University Hospital of the Sacred Heart with her presentation or research entitled Panuveitis secondary to acquired immunodeficiency syndrome, a case study and literature review. And lastly, um, by Dr. Kathy Tripole from the Lung Center of the Philippines to present her research paper on the outcomes of COVID-19 confirmed cases treated with COVID-19 investigational products and intervention in the Lung Center of the Philippines. So again, to our researchers, thank you for joining this forum and congratulations for reaching this far into this platform and initiative. So I think we can start now with the presentation. So to start, we are calling on Dr. Marlon Galvez to present his paper.
Good day. For today's session on treatment and management, I will be presenting my research entitled AEPEI Scoring System to Predict Mortality Among Patients Diagnosed with Infective Endocarditis After Surgery at the Philippine Heart Center, a retrospective cross-sectional study. I am Marlon V. Gatus from the Department of Adult Cardiology, Philippine Heart Center. Infective endocarditis refers to an infection of the endocardial surface of the heart, which includes an infection of one or more heart valves or an infection of an intracardiac device. Establishing the initial diagnosis may be challenging, and antimicrobial and surgical strategies for treatment need to be carefully administered. Despite major advances in diagnostic technology and improvements in antimicrobial selection and monitoring, accompanied by parallel advances in surgical techniques, the morbidity and mortality remains to be high. The precise incidence of IE is difficult to ascertain, because case definitions have varied over time between authors and between clinical centers. In the United States, the incidence of IE was 15 per 100,000 population, while in France, the incidence was 33.8 cases per million. And the 10-year prevalence rate of IE at the Philippine Heart Center was 0.21%, with 21 cases of IE for every 10,000 person days and an incidence rate of 0.14 to 0.29%. Valve replacement and valve repair have become common procedures in the 1960s for the management of selected cases of IE. However, the risk of mortality post-surgery for IE is estimated using predictive scoring systems derived from patient databases, where most of the patients had cardiac operations other than those for endocarditis, and with a reported mortality rate associated with surgery ranging from 15 to more than 45%. A simple scoring system to predict in-hospital mortality was developed by Giuseppe et al., known as the AEPEI scoring system, which includes the patient's preoperative state, an anthropometric measurement, a laboratory finding, an estimate of resting dyspnea, and an ultrasound intracardiac pressure measurement, which perform better than other scoring systems for in-hospital mortality after cardiac surgery. The results of the validation showed satisfactory calibration and discriminatory power of the score. Hence, it is important to identify patients who are at high risk of death or developing complications. Thus, this study is, that is to determine the social demographic and clinical profile of patients diagnosed with infective endocarditis, and to know the sensitivity and specificity of the AEPEI scoring system to predict mortality among patients diagnosed with infective endocarditis after surgery at the Philippine Heart Center. Hence, prompting early recognition in order to decrease morbidity and mortality. This was conducted in compliance with the ethical principles set forth in the Declaration of Helsinki. And prior to the study initiation, the protocol was reviewed and approved by the Philippine Heart Center Institutional Ethics Review Board, and waiver of informed consent was waived due to the difficulty of obtaining individual authorization since the last contact with the research subjects. And this retrospective analytical cross-sectional study was done at the Philippine Heart Center from January 2019 to January 2020 using data from January 1, 2009 to December 31, 2018. All patients who were admitted and diagnosed with definite infective endocarditis on the modified Dukes criteria were included, and patients who did not fulfill the said criteria were excluded, including those with possible and rejected IE, those with incomplete charts, those with no baseline 2D echocardiography, and those who were medically managed. The primary outcome of our study was to identify the sensitivity and specificity of the AEPEI scoring system. Secondary outcomes were to determine the major adverse events like acute kidney injury, end-stage renal disease, sepsis, stroke, cardiogenic shock, and acute limb ischemia. Descriptive statistics was used to summarize the demographic and clinical characteristics of the patients, and frequency and percentages were used for categorical variables, while mean and standard deviation for normally distributed continuous variables. The area under the curve and the receiver operating characteristics analysis were used to determine the diagnostic parameters of the AEPEI scoring system, and Stata 13.1 was used for the data analysis. There were a total of 323 charts with acute and subacute infective endocarditis during the study period. All were reviewed using the actual charts and electronic document viewer at the medical records section. 257 charts were excluded. And the final study sample consisted of 66 charts with definite infective endocarditis who underwent surgical intervention. The mean age of our patients was 36.6, which was comparable to the studies done in Asia by Yap et al., Aherrera et al., and Pasaporte et al. The male-to-female ratio was 1.3:1, similar to a study by Di Mauro et al. The mean BMI of our patients was 22.2, and the mean BMI were much lower than the AEPEI registry because Asian population have lower percentage of fat than the European population. However, in a study by Thorani et al., patients with a BMI of 24 or less were at a significantly increased risk of in-hospital and long-term mortality after cardiac valvular surgery. Fever was the most common presentation, similar to studies by Yap et al. And Sunil et al., followed by dyspnea and easy fatigability. As for the predisposing condition, our study showed that majority of our patients had rheumatic heart disease, similar to previous studies. In the AEPEI registry, critical preoperative state was an independent predictor of hospital death. And our study showed that 3% had a critical state, which is lower than the AEPEI registry. Most of our patients had an ejection fraction of more than or equal to 50%. And severe pulmonary hypertension is related to a higher mortality in a study by Di Mauro et al. And 33% of our patients had an SPOP of more than 55 millimeters mercury, which was higher than the AEPEI registry. The incidence of blood culture negative infective endocarditis varies, with a higher proportion of culture negative IE in developing countries. Majority of our patients have culture negative endocarditis, about 53%, wherein 31.4% had previous antibiotics before blood culture was taken. However, all of the culture negative IE patients in our study demonstrated active endocarditis in the histopathological examination. What could be the reason for culture negative IE? It includes infection with a non-bacterial pathogen like a fungi or a highly fastidious bacteria, or it could be due to inadequate microbiological technique. Transthoracic echocardiography is the first diagnostic test for patients with suspected IE with a sensitivity of 75% and specificity of 100%. The most common type of endocarditis involves the native valve, and single valvular involvement, most commonly the aortic valve, was the most commonly affected, followed by the mitral valve and multivalvular involvement. Vegetation size was also measured because in a study by Verdejo et al., vegetations of more than 10 millimeters are an independent predictor of embolism, and our study showed that 51% had a vegetation of more than 10 millimeters. Our study showed that the most common organisms isolated were the gram-negative bacteria and the Streptococcus species, followed by the Staphylococcus aureus and coagulase-negative staphylococci. The in-hospital mortality rate of IE remains to be high despite advances in diagnostic technology and surgical techniques. And we reported an in-hospital mortality of 10.6%, similar to the study by the Mokles et al. However, when compared to the AEPEI registry, we reported a slightly lower mortality rate, probably because our patients were much younger and with lesser comorbidities. As for the complication, acute kidney injury is a common complication of IE and has been identified as a predictive factor for mortality in a study by Buchholz et al. Several risk factors or risk scoring system has been demonstrated to estimate the risk of mortality after valve surgery in patients with IE. Our study adopted the AEPEI scoring system because it is a simple scoring system and it only used 5 variables. Though the AEPEI scoring system did not include IE-specific variables in its final model, it performed better than the 3 scoring system, namely the DFU score, the PulseU score, and the STS score for in-hospital mortality post-surgery for IE with an area under the curve of 0.78, while on the other hand, AEPEI scoring system was found to be equivalent to Euroscore 2, which consists of 18 variables with an AUC of 0.751. Majority of the patients in our study were under group 1 with 100% survival rate, which was quite similar to the study by Giuseppe et al., probably because patients under group 1 were younger, with no comorbid condition, and had an early detection of the disease condition, which led to successful surgical intervention. While on the other hand, all patients under group 5 had 100% mortality rate, which was greater than the study by Giuseppe, probably because patients were older, presence of other comorbid conditions, and delayed detection of the disease, which led to post-operative complication and in-hospital mortality. Shown in this figure is the receiver-operator characteristic curve of the AEPEI scoring system. The area under the curve was 0.935 with a p-value of 0.001, while the ROC curve was 0.973 with a p-value of 0.001. And according to the results of the ROC curve, the cutoff value to predict risk for mortality is 0.5, with a sensitivity of 100% and specificity of 50%. In conclusion, in patients with IE undergoing surgery, the mortality rate in our institution is much lower compared to previous data. And our results suggest that the AEPEI scoring system is a useful tool to predict in-hospital mortality to help in prognostication as well as clinical and surgical decision-making. As for our recommendation, first, our study was done in a retrospective study, which may influence the quality and consistency of the data being collected. We therefore recommend a prospective study that would include long-term follow-up. Next, the study was conducted in a single center, which can limit the validity of our findings. Hence, we also recommend a multi-centered study, as this study might not have represented the whole population. And lastly, a logistic analysis with greater number of sample size is suggested to determine the variables that affects the prognosis of each patient. Thank you and good afternoon.
So again, thank you very much for your presentation, Dr. Gatus. Um, for the question and answer portion later, we will be sending, or we will be doing the Q&A after the presentation of the three presenters will be done. So the next presentation would be from Miss Yasai from St. Louis, with her study on the Panuveitis secondary to immunodeficiency syndrome or AIDS, a case study and literature review.
Good afternoon, everyone. Today, I'm going to present to you a case study and literature review on Panuveitis secondary to acquired immunodeficiency syndrome. I am Lorraine Diasay, staff nurse of St. Louis University, Hospital of the Sacred Heart, together with Mr. Aldrin R. Raymond, our chief nurse, and staff nurse Cristabel A. Barignasay as my co-authors. To start with, the background of the study, human immunodeficiency virus continues to be a serious health threat in the Philippines, with a record high of 32 infections daily. Panuveitis is the earliest ocular manifestation found in patients with acquired immunodeficiency syndrome. The ocular complications occur in up to 70 to 80% of untreated HIV-infected patients, and more than half are associated with uveitis. So notably, uveitis in patients presenting with HIV syndrome may be more severe. Panuveitis is the only presentation of ocular syphilis, leading to a diagnosis of AIDS is very rare. The objective of this study aims to describe a rare case of ocular syphilis in a patient with acquired immunodeficiency syndrome. The study further aims to identify the laterality and severity of the disease. We have used qualitative case study as a research design. So this research employed a case study approach to facilitate an in-depth multifaceted exploration of the interest in its natural, real-life context. We have utilized 4 stages of um, research process, namely defining the case, selecting the case, interpreting data and literature review, and reporting of findings. We have taken some ethical considerations such as informed consent. So first, an informed consent from the patient was secured, and after securing an informed consent, a letter was sent to the hospital administration prior to commencement of this study. The aforementioned information on the key elements of this study, such as the purpose, procedures, time, list, and benefits were discussed. And we complied with the provisions of data privacy law. The results and discussions. Our client is a 24-year-old male, single, Filipino in nationality, and Anglican in religion. Our client is a call center agent in a same-sex relationship for almost a year, owns a small business with his siblings, lives in a non-congested neighborhood with other 6 household members, has a good interpersonal relationship with his family, relatives, and friends, and a non-smoker but occasional alcohol drinker. Our client sought consult in our institution due to severe pain on the left eye, with diminished vision, itchy skin rashes on both upper and lower extremities. With a history of present illness, 7 months prior to admission, the client noted reddish, itchy rashes on both upper extremities. And 5 months prior to admission, there is an increased formation of maculopapular erythematous lesions over his legs and arms, sparing the body and face. 3 months prior to admission, small non-painful vesicles over the upper and lower extremities, and there is erythematous macular lesions over his face with noted excoriations. 1 month prior to admission, patient started to experience headache at the frontal area followed by left eye pain associated with visual symptoms of dry eyes and cloudy vision. 2 weeks prior to admission, he consulted an ophthalmologist and managed a case of dry eye syndrome and was given atropine eye drops and prednisone. On subsequent follow-up, there was still elevated platelet count and persistence of visual field loss, hence referred to another physician wherein he was advised for admission and further workup. So in our assessment, these are the photos taken with patient consent. In the laboratory result, HBsAg screening non-reactive, anti-HBs screening reactive, anti-HBe quantitative non-reactive. Our client is reactive from encephalitis screening, PPPA quantitative, positive, and 66 cells of CD4 count. So to explain further, a TPPA, also known as the treponema-pallidum particle agglutination assay, is an indirect agglutination assay used for the detection of and titration of antibodies against the causative agent of syphilis, while CD4 count are the white blood cells that fight infection. CD4 cells is an indicator of immune function in patients living with HIV and one of the key determinants for the need of opportunistic infection prophylaxis. A normal CD4 count ranges from 500 to 1,200 cells. A low CD4 count indicates that your immune system has been infected by HIV or the disease is progressing. The nursing intervention and diagnosis. The nursing care for this patient is focused on three major problems, including risk for infection or onset of new opportunistic infection related to suppressed immune response. So we practice good infection prevention and control. Second, defensive coping related to fear of rejection and chronic low self-esteem related to perceived lack of affection and acceptance from others. In addressing these problems, we utilize the nurse-patient interaction as the main tool in providing interventions. As an outcome, medical management and nursing interventions done during hospitalization and medications given after discharge help reduce patients' chances of acquiring opportunistic infections. It also improves his eye vision and overall skin condition. With the help of antiretroviral therapy or treatment and the compliance with the treatment regimen, the patient shows an overall improvement in both virological and immunological response. In conclusion, public health and nursing care for people living with HIV are focused on treatment, psychological, and social care. Nurse-led interventions are effective in fostering antiretroviral therapy adherence among people living with HIV. Future public health research is needed regarding the effectiveness of existing strategies to enhance the HIV cascade of care, but not limited to innovative responses and addressing emergent challenges. Thank you.
Next, we will be hearing from Dr. Kathy Tripole with her study on the outcomes of COVID-19 confirmed cases treated with COVID-19 investigational products and intervention in Lung Center of the Philippines.
Good day, everyone. It is an honor to share with you our study entitled Outcomes of COVID-19 Confirmed Cases Treated with COVID-19 Investigational Products and Interventions in Lung Center of the Philippines. I am Dr. Kathy Jane Tripole from Lung Center of the Philippines, and my co-authors are Dr. John Edwards Rivales, Dr. Virginia de los Reyes, and Dr. Mary Claire Arden. COVID-19 has caused a global pandemic with no evidence for any specific treatment until now. In the meantime, investigational therapies are being explored which targets viral inhibition, suppression of the secondary effects of cytokine storm, and modulation of host immune system to mount its defenses. The Lung Center of the Philippines was one of the first COVID referral hospitals appointed by the Department of Health to be the COVID-19 referral hospital catering to moderate to critical cases. So during the start of the pandemic, there was no established guideline or standard of care, and we depended on the evolving recommendations and the use of various investigational therapies for our patients. Thus, we came up with this study to determine the outcomes of COVID-19 confirmed cases treated with COVID-19 investigational products and interventions in terms of mortality, morbidity, and length of hospital stay. We hope that the results of this study will help guide us clinicians in the choice of investigational products, and that this could contribute to the local and global data in the real-world treatment outcomes of using these therapies. The objectives of this study was to determine the outcomes of COVID-19 confirmed patients treated with investigational products and intervention in the Lung Center of the Philippines from March 7 to August 31, 2020 in terms of in-hospital mortality, morbidity, and length of hospital stay. Specifically, determining the morbidity in terms of use of mechanical ventilation, use of higher form of non-invasive oxygenation, and the presence of adverse drug event or adverse drug reaction. This is a retrospective study done in Lung Center of the Philippines involving COVID-19 confirmed cases, age more 18 years old and above, diagnosed by SARS-CoV RT-PCR, those classified as moderate, severe, or critical based on the World Health Organization guideline, those admitted from March 7 to August 31, 2020, and those who received at least one investigational product or intervention, such as hydroxychloroquine or chloroquine, with or without azithromycin, lopinavir, ritonavir, remdesivir, favipiravir, interferon, tocilizumab, hemoperfusion, convalescent plasma, and combination of these products. We did a retrospective patient chart review and laboratory data extraction through an electronic hospital record software called BizBox. So the assignment of investigational products was physician-initiated or depended on the randomization under Solidarity trial if the patient was enrolled under it. A total of 499 patients were screened and 376 patients met the inclusion criteria, excluding mild cases and those not receiving any investigational product. Our study involved subjects with mean age of 58 years old. Majority of them were male, comprising 65%, non-smokers, comprising 74% of patients, 46% are of moderate, 42% are critical, and 12% are of severe disease. 84.6% of these patients have at least one comorbidity. Most of them had hypertension, followed by diabetes mellitus and cardiovascular disease. The overall in-hospital mortality found among these patients is as high as 41%, owing to the exclusion of mild cases, and that majority of cases that were admitted in our institution are of severe to critical disease. The average length of stay is 14 days. For our first outcome on in-hospital mortality, this graph shows death and discharge rate among the different investigational products and interventions used. The blue-colored part of the graph represents discharged patients, while the red part represents death. Overall mortality was highest among those patients given convalescent plasma at 71%, combination of steroid plus hemoperfusion at 68%, and hemoperfusion at 64%. However, it is noteworthy to mention that the mortality rate among critically ill patients, regardless of the intervention used, was high at 57 to 88%. So regardless of the medication or the intervention given, those with critical severity has high mortality as represented by the red part of the bar graph. We should also consider the fact that before the widespread availability of tocilizumab and the compassionate use of remdesivir, there are some patients of severe and critical severity who may unfortunately receive no investigational medication, including those patients under Solidarity trial, randomized under standard of care. So these patients are given steroids and hemoperfusion that are readily available in our institution, and this may reflect the frequent use among these patients in this graph. For our second outcome of morbidity, specifically with the use of mechanical ventilation, this graph shows the rate of intubation in decreasing order. The highest rate of intubation was noted among patients given hydroxychloroquine, chloroquine, with or without azithromycin plus tocilizumab. Next is patients given convalescent plasma, and third is patients given combination of steroid plus hemoperfusion plus tocilizumab. So in the early months of the pandemic where hydroxychloroquine was introduced, it was also the period where invasive ventilation was advocated over the use of non-invasive approach due to fear of aerosolization and the lack of data and guideline. So this could probably explain the high rate of intubation among this group of patients. The lowest intubation rate was among patients receiving favipiravir, probably because most of these patients are of moderate severity. Here we have steroid with low intubation rate at 18%, remdesivir at 21%, and combination of steroid plus hemoperfusion at 24%. So the lower rate of intubation among those with steroid in this case is also consistent with several studies, particularly the recovery trial, where the need for mechanical ventilation among those given steroid was actually lower. For our second outcome of morbidity, specifically with the use of higher form of non-invasive oxygenation, this graph shows the need for it in decreasing order. So there were more patients who eventually needed higher form of non-invasive oxygenation among patients given combination of steroid plus hemoperfusion plus tocilizumab, next dose with tocilizumab and interferon. Again, this could be attributed to the fact that these patients are of severe to critical disease severity. Those given hydroxychloroquine, as you can notice, have lower rates of being shifted to higher form of oxygenation since, as shown in the previous slide, they were already needing mechanical ventilation. For our second outcome of morbidity still, specifically on the presence of adverse drug event, the most common adverse drug events were transaminitis with 6 cases, 5 cases of arrhythmia, 5 cases of bleeding, 4 cases of acute kidney injury. Other adverse drug events were 2 cases of prolonged QTC interval, 1 case of ischemia, 1 case of seizure, and 1 case of allergic reaction to remdesivir. Investigational products with most adverse drug events were hydroxychloroquine plus azithromycin of 7 events, interferon of 6 events, remdesivir with 4 events, and combination of steroid plus hemoperfusion plus remdesivir of 4 events. Favipiravir has 1 case of transaminitis. There was also note of bleeding found in investigational products with established bleeding risk, such as steroids and hemoperfusion. And it is prominent in this case when the two of them are combined. However, these adverse events could also be attributed to the disease pathology of COVID-19 rather than the investigational product alone, since COVID-19 itself can have an effect on our multi-organ system. For our third outcome, in terms of length of hospital stay, the ones with the shortest hospital stay in blue underline are with the use of steroid, favipiravir, steroid plus hemoperfusion, and steroid plus hemoperfusion and remdesivir. While those with the longest length of hospital stay were those given convalescent plasma, lopinavir, ritonavir, and combination of hydroxychloroquine plus tocilizumab. However, we have to be reminded that during the pandemic, there were evolving criteria for hospitalization and discharge, and this made a great impact on the difference in the length of hospital stay through time. And during the conduct of the study, there was also not enough data and researches on these outcomes. So in conclusion, in terms of the outcomes of COVID-19 under moderate to critical severity, overall in-hospital mortality rate is high at 41%. The average length of hospitalization is 14 days. Patients with critical severity has a high mortality regardless of what kind of interventional product or intervention was given. And determination of adverse drug events among COVID-19 patients using investigational product is difficult due to its multi-organ involvement. So in line with this study, we recommend the need for further researches involving greater number of patients using investigational products, especially with the use of hemoperfusion, favipiravir, and steroid. Though we now have evidence of benefit from steroid, still we may need local data for an analytical study. Second is for us to review the common adverse events among those using investigational products, as some may go unnoticed and perhaps we may need specific guidelines on how they can be managed and followed up, since it can present a serious long-term complications that we could actually prevent. Third, due to the high rates of mortality, the need for mechanical ventilation, and the need for higher form of oxygenation among these patients, we need to support our health sector's efforts in establishing sustainable healthcare preparedness in facing emerging and re-emerging infectious diseases such as COVID-19. So we hope that by this study, we were able to share our findings, our very own experience, and our purpose to help end this pandemic so we can all heal as one. Again, thank you and have a good day.
Our first question for Dr. Gatus, how can this improve the overall preoperative process or procedure should this be adopted?
Hello, ma'am. So thank you for that question po. So how can we improve the overall preoperative procedure of the patient? So we can apply this because it is a simple tool using only 5 variables. Because at the Philippine Heart Center, we use the Euroscore 2, which consists of 18 variables. But this tool can be easily placed. There is an app for that, the Euroscore 2. So madali lang siyang gawin. Pero yung AEPEI scoring system only use 5 variables. The only difference in the Euroscore 2 that we use in the Philippine Heart Center is that the AEPI included the body mass index, which is not present in the Euroscore 2. But according to the study by Giuseppe et al., they included the BMI in the Euroscore 2, but it did not. It showed that there was no added value to be derived from adding the BMI to the Euroscore 2. So I think we can easily adopt the AEPI scoring system in our institution because it is simple and only uses 5 variables. Thank you.
Thank you, Doc. There is another question po. So, what is the scoring system being used in PHC, and what is the difference between the two?
As what I've said earlier, so the scoring system being used at our institution at the Philippine Heart Center is the Euroscore 2, which consists of 18 variables. So sobrang dami ng variables noon. So we can place it in the app or we can use the internet to compute for the risk of mortality for patients undergoing valve surgery. The only problem with the Euroscore 2 is that it is only used for patients undergoing valvular surgery. Though it included a variable there that like for example, the patient has or do not have an active endocarditis, but it did not include i.e. Infective endocarditis specific variables. So for the difference between the two, just like what I said, is the AEPI scoring system included the body mass, the mean body mass index in the parameter, which the Euroscore 2 did not include. Thank you.
Thank
Doc,
you po, Doc.
all right. A follow-up question with regarding to the tool. Currently in your institution, how are you using these researches or research in terms of standard for clinical management? And at this point in time, is this something that can be adopted as a standard of care even within the facility of the heart center?
Thank you for that question, sir. Sir, yes, we can adopt it. However, we can do further studies. We should compare head-to-head the Euroscore 2 and the AEPI scoring system. So it can be a future research for the cardiology fellows.
Okay, thank you, Doc, for that answer po. Maraming salamat. JJ?
Oh, okay. This question is for Miss Lorraine Yasay. So, may we ask Miss Lorraine po to open her camera po? Thank you. So, how can this study encourage more nursing intervention, intervention related research in the future? And how did the nursing-led intervention improve adherence in ART adherence based on clinical case?
Hello.
Sorry, I didn't hear any questions.
Sorry. Sorry. So I'll just repeat the question. So, um, how is this particular result or the result of the study compared to the international ano po no, CPG or yung available CPG for treatment daw?
Compared to the international CPG.
Yes po.
Okay.
Opo.
Um, Actually, right now, that the study that we did was just a descriptive type of study showing trends using frequency and percentage. So we could not actually make an ideal comparison with the other international studies because most of the studies done and released were of analytic study and most comprise of bigger population. But then we see a consistent or trend of benefit with regards to the use of steroids. For example, in our study, in this particular study, we see a benefit in the decrease of mortality, the decreased use of invasive ventilation, and higher form of oxygenation, which is also similar to, for example, the recovery trial. And then we also see in this study that we have benefits for the use of hemoperfusion and other studies and other investigational products. However, this study only has small population and we could not conclude any any more further benefit from it. But I think this study will help us build can help us have other studies as a support for this one.
Right, Doc. Thank you. Just another follow-up question po, Doc. No. So how do you think can we engage the current medical society so that we'll be able to come up with a better or parang a more comprehensive research in terms of the scope, in terms of establishing this ano po standards of care, Doc Cathy?
Hello? Hello po. Available na po
Hello.
ako.
We
Again,
can hear you na po, Doc.
all right. So, okay. Siguro we'll go get back to Dr. Kathy in a few. So we'll just ask a few questions po to Ma'am Lorraine. So, I think the question a while ago was, first is, how can this study encourage more nursing intervention related research in the future? And how did the nursing led intervention improve adherence in ART adherence, specifically for your clinical case, ma'am?
Okay. So, this study highlighted that the case study research is proven particularly significant for studying emerging infectious diseases, evaluating public health programs, and informing policy. With the use of a prospective analysis in a collaborative, multi-center approach, research designs can facilitate therapeutic trials and provide valuable breakthrough in managing some of the most refractory site-threatening types of this disease and this case.
All right. For the second question, ma'am, how did the nursing specific for your patient po, no? How did the nursing intervention improved adherence specific for your patient po?
Hello?
Yes, ma'am.
Yes po. Hello?
Hello, yes po. So the second question po was ano po, no? Um, specific for your clinical case, how did the nursing ano po, led intervention improved adherence of your patient po to ART adherence to ART po?
Mukhang nawala ulit si Miss Lorraine.
Di po, no? Alright, sige, siguro ano po, the rest of the questions can be answered na lang po after. Is Doc Cathy available already
Hello, sir. Yes.
for the final? Yes po, Doc.
Yes, sir.
Were you able to hear the last question for you po? Yung question about how the medical societies be engaged to strengthen or to strengthen the evidence po that lung center did as an initial study.
Okay. Maybe for the subspecialties or the medical societies, we could encourage them to investigate or focus on the more common investigational products available locally. So, for example, we could start with the use of hemoperfusion, steroid, and have it compared with a standard of care, since we know that we have evolving guidelines or standard of care treatment. So maybe we could um, have an analytic researches on this common and available investigational products.
So I think that's all the time that we have also and the available questions for the Q&A. So I think just to summarize this entire session, so we have heard about how AEPEI scoring can be a useful tool to predict inpatient or in hospital mortality to help in the prognostication as well as the clinical and surgical decision making in terms of standards of care. No? So Dr. Gatos mentioned a while ago that this can be actually a useful tool for a preoperative planning and decision making for patients. So we've also heard from Ms. Yasay the importance of nursing care in the overall management and journey of people living with HIV. So that particular case study provides us with a glimpse on how nursing care adds value to the overall patient outcomes and adherence to treatment or management. And lastly, we also heard a study on the outcomes of evolving treatment regimens among COVID-19 confirmed severe and critical cases admitted at the lung center of the Philippines. So this study can serve as evidence to strengthen the current pool of knowledge of our treatment management and contribute to the ever-evolving CPG development for COVID-19 care. So, and I think that's all that we have for this particular parallel session on treatment or management of the clinical and public health track of the first National Hospital Week Research Forum. So again, congratulations to all our participants po no who presented with us today. Especially ang dami pong nag-submit ng mga research proposals po and kayo po yung mga napili um na mga na research po to present with this actual forum. So before the first National Hospital Week Research Forum formally closes, the link to the post-activity evaluation form will be announced and posted, and all those who will be able to fill up the online post-activity evaluation form will receive a certificate of attendance in return. So I think officially we are closing this parallel session po, no? And thank you for all your participation.